Anyway. All right, so lipedema, an overview. Well, unfortunately, lipedema is often referred to as disease they call fat. Now, a much more appropriate and up-to-date definition would be as follows, along as a lot of other characteristic manifestations we'll talk about, is that lipedema is now recognized as a congenital, often familial disorder of the loose connective tissue. Very, very important. And as you'll see as well, it's not just about big legs. Lipedema patients have protein manifestations, which we'll go over. There are no diagnostic tests for lipedema, as Jonathan alluded to, and lipedema is a clinical diagnosis based on history and physical examination, hence the reason I'll be speaking today. So why talk about lipedema or lipedema? Either is fine. I kind of like lipedema because when you say lipedema, it sounds like lymphedema, and it's often confused with lymphedema. So you'll catch me saying lipedema a lot of the time. Well, first of all, as Jonathan referenced, lipedema is frequently misdiagnosed as simply being obese. Lipedema is frequently misdiagnosed as lymphedema. And this adage, it's already been referenced twice. It's on the sign outside from Benison and Edelglass's 1984 article. Lipedema is not rare, but the diagnosis is rarely made. And Jonathan, as you alluded to, the true prevalence is really not known. You'll often see 1 in 10. I'm not convinced it exists in 1 in 10 of the population, especially classic lipedema. I don't believe that's the case, but we just don't know what the prevalence is for sure. So let's review the clinical manifestations. So if you go all the way back to 1951, in this classic article by Dr. Wold and Hines at the Mayo Clinic, they recognized 6 cardinal clinical features of lipedema which have clearly stood the test of time. So let's review these 6 cardinal clinical features, almost exclusively female, 99.9%. Bilateral and symmetrical with sparing of the feet, at least in classic lipedema. A component of minimal pitting or orthostatic edema at the end of the day within the calves and the ankles, hence the term lipedema. 90% of these patients, at least, have significant pain and or cutaneous tenderness. If you don't have pain or tenderness, then the diagnosis is truly in question from my standpoint. And as referenced, a tendency to easy bruising, which complicates at least 70 to 80% of these patients. That triad, that clinical triad there is really important in distinguishing lipedema from, let's just say, obesity. And finally, persistent enlargement of the extremities after elevation, and extremely importantly, persistent enlargement of the extremities even after profound weight loss, which underlies the adage, you can't starve lipedema. Amazing how back in 1951, these manifestations have stood the test of time. So here are 2 highly illustrative examples of the unique somatotype of the patient with lipedema. You see this symmetrical or excessive disproportionate deposition of fat within the limbs that relatively spares the torso. There's a mismatch, if you will, between the size of the torso and the lower extremities. It's not uncommon when you're seeing lipedema patients that they'll tell you that, oh yeah, I have to buy or purchase different size tops and bottoms. There's a mismatch. These patients have somewhat of a pear-shaped configuration. Now, I want to draw your attention to the top of that black arrow. What do you see there? There's a cicatrix or a scar. This patient was told you're morbidly obese, you need to lose weight. She underwent a gastric bypass surgery. She lost 130 pounds, and look what happened. Look at that torso. There's no more excess adipose tissue on that torso, but look at the limbs. Again, underscoring this adage, you can't starve lipedema. So as I referenced, lipedema is often mischaracterized as lymphedema. So let's go through the 3 salient clinical differences between classic lymphedema and classic lipedema. Lymphedema on the left, lipedema on the right. First of all, lymphedema can be unilateral, it can be bilateral. Lipedema is always bilateral, assuming they haven't had an amputation. Lymphedema, even when it's bilateral, there tends to be some asymmetry in the legs, as you see here, versus lipedema should be relatively symmetric, as you see here. And then finally, classic lymphedema, typically, although not invariably, is associated with significant swelling of the feet and toes, whereas lipedema is typically, although not invariably, associated with foot or toe sparing from a swelling standpoint. So really good contrast between these two disorders, and you shouldn't be confusing the two. Now, before we go any further, there's a very important differential diagnosis for lipedema that I want to reference, and it has to do with pain. So both of these examples I am showing you here, you see the excessive disproportionate symmetrical swelling of fat within the limbs with relative sparing of the torso. They have a mismatch. However, what if I told you that these patients don't have pain? If they don't have pain, do they really have lipedema? I'm not convinced they do. So what would you call it in this case? Well, I like how the Europeans break this down into what they would term lipohypertrophy. And if you go through all these clinical manifestations on this table and contrast lipedema with lipohypertrophy, they're exactly the same with the exception of two manifestations. Pain, it's present in lipedema, it's absent in lipohypertrophy. Orthostatic edema, it's present in lipedema, it's absent in lipohypertrophy. Now, I'll be the first to tell you that this distinction is not universally recognized. You'll see it more often in European literature than in the United States, but I really like it. If a patient doesn't have significant pain or tenderness, I'm not convinced they have lipedema. If they do, it may just be an early form thrust, if you will, of lipedema. So I like lipohypertrophy. So on to the characteristic clinical manifestations of lipedema. Unique somatotype here is the ankle cuff sign. What a great example of the ankle cuff sign, where this symmetrical disproportionate fatty limb swelling abruptly terminates at the level of the malleoli, as you see here. Another great example of the ankle cuff sign, with the termination of the fat right above the malleoli. And you'll also note foot and toe sparing as well. So just want to get you used to looking at a patient's legs with lipedema. Once you see that, it's just immediately, patient's got lipedema. It's not lymphedema. What do you see here that's also very characteristic of lipedema? Well, there's a big patch of ecchymosis here. The patient with lipedema is predisposed to easy bruising and spontaneous hematomas. It complicates up to 70 to 80% of these patients. And that begs the question, why is this occurring in the setting of lipedema? Well, it's due to the associated, Jonathan, your slide showed capillary fragility, small venous capillary fragility. Well, why do they have fragility? Well, because those vessels reside within a bed of dysfunctional loose connective tissue, which causes that fragility and tortuosity enlargement and a susceptibility to easy bruising. Note the ankle cuff sign there. Another great example. Look at all these bruises in that patient with classic lipedema, and note the characteristic ankle cuff. All right, another unique phenotype of a lot of the patients that have lipedema. What do you see here? Well, you see this protuberance of fat that overlies the lateral malleolus. This is referred to as the lateral malleolar fat pad sign. All three of these subjects have very prominent lateral malleolar swelling. And I find this sign very useful because if you don't see it in lipedema, I'm always questioning the disorder, but it's also useful a lot of times when you see these patients early and you're not really sure if they have lipedema. This is one of the earliest manifestations you'll have in lipedema. So always check the lateral malleolus for associated focal swelling. Very, very characteristic. Lipedema is associated with significant skin laxity. Note this very loose, sagging tissue. And why do they have skin laxity? Because it's a disorder of the loose connective tissue. Another great example of the skin laxity that complicates the patient with lipedema. If you were to palpate their limbs, this is a very rubbery consistency. It's non-pitting. Assuming you're not examining their distal calves or ankles at the end of a long day when they've been on their feet, then they could have some pitting orthostatic edema. And then finally, very unique, it's not exactly specific, but quite unique to the patient with lipedema is not infrequently they are complicated by subcutaneous nodules. When they're large are lipomas, but more frequent than lipomas are actually the following. If you carefully palpate under their arms and their legs, you'll feel what feels like all these sheets of BBs, been likened to frozen peas. They've been likened to rice. These are actually spheroids, which represent inflammatory fat deposition within nodules. Spheroids are very, very common. They're easier to feel, you just have to do it on your examination. Let's go on and talk about the different lipedema phenotypes. There are 5 classic lipedema phenotypes. Type 1, relatively rare, just involves the buttocks and hips. Type 2, buttocks to knees. Type 3, buttocks to ankles. By the way, that is the most common lower extremity phenotype. I'll show you this again on the next slide. Type 4, involving the arms and the legs. And you'll see overall that's actually the most common phenotype you're going to see in a lipedema patient. And finally, there's a rare phenotype, type 5, where the swelling just extends from the knees to the ankles. Now, that's the classic 1 through 5 phenotypic classification of lipedema. Now, I like the way this is from the German Society of Phlebology and from their lipedema guidelines. They utilize a much more simplistic and I think descriptive example of the localization of lipedema distribution. So let's look at the arms. It either involves the legs. Let's look at the legs. It either involves the upper legs, it either involves the full leg, which is the most common phenotype, or it simply involves the lower legs. And there's the same type of breakdown in the arms. Now, from an arm standpoint, upper arm involvement is much more common. So I really like this, especially going, oh no, another classification scheme I have to remember, 1 through 5. Just use this distribution scheme here. Very descriptive, simplistic, and I think it works very well. All right, so just some examples of the most common lower extremity phenotype. That's your type 3 or the full leg type, where the disproportionate fatty limb swelling begins in the hips and extends all the way down to the ankles, terminating in an ankle cuff sign. 2 really good examples. That's the most common phenotype. But the second most common phenotype is an upper leg type, where the symmetrical disproportionate fatty limb swelling begins in the hips and it terminates at the level of the knees. 2 really good examples here. It's interesting when you read the literature, sometimes you'll see this referred to as a Jodhpur pants type fat deposition. It's actually in the literature. Oh, plenty of time. And then finally, this is a rare type. I don't see a lot of these. It's the type 5 or lower leg type, where you can see the preponderance of lipedema begins in the knee and terminates at the level of the ankle. 2 really good examples. Now, you may argue, you see a little bit of that laxity on her thighs, that, well, the patient looks like a full limb type. That's true, but yet look where the majority of that swelling is. It's mainly in that infrageniculate distribution. And you'll see this referred to as cankles. Like the patients, they'll tell you, they say, well, yeah, I've had cankles all my life. And you look and it's a type 5 or lower limb type lipedema. And really what you're going to see if you pay close attention is a combination of full leg type swelling and upper arm type swelling. Because what the issue is, and these patients come in, they don't come in complaining about their arms. They come in complaining about their legs. So if you don't do a thorough exam, you're going to miss this. But 2 just incredible examples of a full leg type with an upper arm type. And look at that woman on the right-hand side. She exercises 2 hours per day. You don't see any fat on her abdomen whatsoever. Isn't that extraordinary? Want the black garments on? Truly extraordinary example of lipedema. And back to the arm. It was interesting. If you looked at the older literature, it used to say about 1 in 3 lipedema patients have involvement of the arm. But thanks to Dr. Herbst and her associates, it's now recognized that 80% of your patients with lipedema have associated swelling of the arm. Usually it's the upper arm type. Sometimes you'll see it going all the way down the arm and terminating at the level of the wrist with a wrist cuff sign, which is analogous to your ankle cuff sign. When you see this upper arm involvement, it's interesting, you ask your patients about this, they'll say, oh yeah, here's my bat wings. I've heard that so many times from my patients, also referred to as angel wing deformities. So very common, you just have to do a good physical examination to pick it up. So we talked about the phenotypes. Let's go on and talk about the stages of lipedema. We'll go back to the German guidelines. These are helpful. We got stage 1, 2, 3. Stage 1 is the smooth stage, where you have this somewhat thickened, smooth skin in early lipedema. Now moving on to a stage 2, this is our nodular stage, where you look at the tissues, they're uneven, they're undulating, they're waxy and wavy appearing, and they're knotted when you feel them, or nodular. And then finally in stage 3, you get these big overhanging growths of fat when this is our lobular stage. And I've got some good examples of all these that I'll show you. And then finally, just to be complete, you'll also see, if you read the literature, there is a stage 4 lipedema that shows up out there. And stage 4 is defined as lipedema with secondary lymphedema, also known as lipolymphedema. I'm not a big proponent of the stage 4, and as far as why, I agree with what the German Society of Phlebology says about this. And they state as follows: a progression to lipedema with secondary lymphedema can occur at any stage, partly depending on comorbidities such as obesity, inactivity, chronic venous insufficiency. I completely agree. You can see transient foot swelling in all of these stages, or even permanent foot swelling in all of these stages. So not a big fan of stage 4. So let's go over some photographic representation of these 3 stages. 2 great examples of stage 1. Note how smooth that skin is in both of these subjects. That one on the left there is an upper leg type, obviously, full leg on the right. Let's look at the nodular stage. Now you begin to see that waxy undulations, that loose tissue within the thighs predominantly. Although if you look at the subject on the left as well as the right and look down their calves, you'll also see some laxity in the tissues. Now, this appearance of the overlying skin has been likened to a mattress. You'll see mattressing phenomenon charted sometimes with lipedema, or the shell of a walnut. Stage 2 nodular lipedema. And then finally, the worst stage, lobular lipedema, where you can see the fatty overhanging distribution. The Germans refer to these as dewlap deformities. I gotta admit, I haven't charted dewlaps yet in my notes. And look at this. The dewlaps are not just in the thighs. In these severe cases, they can involve the calves as well. Look at those dewlaps. Now, note in this case in the middle, I mean, that's obviously really impressive lipedema, but yet, look how that swelling abruptly terminates at the level of the ankle with the cuff, and there's no concurrent foot involvement. Guess what that patient was referred to me with what disorder when I saw her? Lymphedema. Please see this patient with lymphedema. I mean, that's like you walk right in. They may have some secondary lymphedema, but that's lipedema. It's about as obvious as it gets. Now, if you see enough lipedema patients, you'll realize there's a lot of hybrids of lipedema out there. Let's go through some of these hybrids and what I mean by that. In the presence of time, obesity, inactivity with failure to activate the venomuscular pump, as well as chronic venous insufficiency, it's not uncommon that your patients with lipedema will go on and develop fixed foot swelling within the dorsum of the foot consistent with secondary lymphedema, also referred to as lipolymphedema. And there are 2 very, very good examples of lipedema complicated by secondary lymphedema. Important point, I like this. This is actually from the United States guidelines. Consensus statement 1.12, women with lipedema who develop lymphedema have lipolymphedema. Lipolymphedema is lipedema that's progressed to clinically identifiable lymphedema with permanent swelling in the dorsum of the foot, a risk that increases concomitant with stage. And if you just look at the severity of foot swelling in all of these stages, you'll see it's more severe in the stage 3 than it is to stage 2 and the stage 1. I mean, that's an intuitive observation. Now, importantly, as you've seen in the previous photos, patients with lipedema and secondary lymphedema or lipolymphedema typically have minimal to a very modest amount of foot swelling. I mean, you see that subject there in the middle of the screen, which has pretty severe lipedema. You see some foot swelling there, it's fixed, but it's not that severe. And that you contrast that with the following. What are we dealing with here? Where you see that marked dorsal curvaceous foot swelling consistent with primary lymphedema. So you really have a disparate amount of foot swelling between lipedema, complicated by secondary lymphedema, and typical lymphedema, especially primary lymphedema with marked foot swelling. Now, although grossly underappreciated in the medical literature is the association of lipedema not only with secondary lymphedema, but chronic venous insufficiency. This is not uncommon, but it's just amazing when you review the literature. They will show you pictures of a patient with lipedema that look just like these, and there's no reference to chronic venous insufficiency whatsoever. Boggles my mind. But yet, in data from my institution, we looked at our lipedema patients, 50% of them, this is actually one of the subjects from the study, had associated stasis hyperpigmentation. And the one on the right there, you can see there's some induration and regression there of the skin. They don't just have stasis hyperpigmentation and dermatitis, they have lipodermatous sclerosis as well. So again, this is not uncommon in the setting of lipedema, especially when they have associated obesity. It's not uncommon at all. But a very important point I want to make here, that when you look at these limbs, the preponderance of that swelling is mediated by their lipedema. It's not mediated by their lymphedema. It's not mediated by their chronic venous insufficiency. Both of those are additive. The preponderance is due to the lipedema, the swelling. Because that gets lost, and it's a whole different conversation on all these poor patients with lipedema that I see that undergo ablation of their great saphenous veins, being told that, oh, that'll take care of your swelling, and it doesn't do a whole lot for the swelling. Now, as I referenced earlier, lipedema is a disorder marked by 10 more minutes, protein manifestations. So it was interesting, there was a questionnaire that was sent out by one of the German phlebologists about a year or two ago where they wanted to rename lipedema, and they had a bunch of different choices. And the one they came up with, which I really think is pretty good, I like this, is lipedema syndrome, because it's not just about big legs. They have syndromic features. And let's go through some of these syndromic features. First of all, musculoskeletal. So you look at this limb here, and what do you see in the limb? You see this knock-kneed appearance, also known as a genu valgum or a genu valgus deformity, right? That's a pretty good example of genu valgus deformity. But a lot of people would say, well, of course they have that. That patient is, they have significant obesity. That's why they have the genu valgum deformity. However, how do you explain it in this situation? This patient doesn't have obesity, and they have a genu valgus deformity. Why is this occurring? Because lipedema is associated with dysfunctional loose connective tissue, which predisposes them to joint laxity. And Karen Herbst was actually, in her group, were the first to really promulgate this idea that lipedema is associated with hypermobility, and that it is indeed a connective tissue disease. And in fact, her studies have shown that at least 60% of patients have a pathological Batten hypermobility score of 5 or greater. And these are all incredible examples of patients of mine with lipedema exhibiting significant hypermobility. I mean, you see the one there that bending over with her knees extended and palms can still touch the ground. That's one point there on the Batten scale. Now, the one in the middle, the reverse namaste sign, it's not part of the Batten score, but it's still kind of cool to ask them to do that. And then finally, at number 3, where you oppose the thumb to the forearm, that's worth a point on the Batten scale. This is really easy to do. It adds all of 2 to 3 minutes to your physical examination. It's not hard at all. More examples of hypermobility syndrome. Now here, you're seeing the point given for apposition of the thumb on the forearm, but what do you notice about the skin? Very characteristic of patients with connective tissue disease, including lipedema. It's extremely thin. You can see right through that skin. Very, very characteristic of patients with lipedema. There's elbow extension beyond 10 degrees. That's worth a point on each side. Note the bat wing deformity. If you can extend the finger beyond 90 degrees, that's a point right there. And then finally, when they stand, if you can get knee extension beyond 10 degrees, that's referred to as genu recurvatum. You get a point for each knee that's hyperextended. Note the lateral malleolar fat pad sign there. And sparing of the feet. Foot pain is extremely common in patients with lipedema. Well, why would a lipedema patient have foot pain even in the absence of obesity? Neither of these subjects are obese and they have significant foot pain. What do you note there? You note the flat feet. They have pes planus. And if you look at them from behind, a posterior approach, you'll notice they usually have ankle pronation as well. And they look like that. So why do they have pes planus, ankle pronation with subsequent foot pain because of the joint laxity, because it's a connective tissue disease. Here's a very common manifestation in your patient with lipedema. What are we looking at here? These compressible, reproducible herniations of fat that overlie the calcaneus. Sometimes we'll see it along the lateral portion of the foot as well. These are referred to as pisogenic papules. And why are you getting herniated fat in the setting of lipedema? Not only do they have joint laxity, they have dermal laxity as well, which is why they have the loose sagging skin, and it predisposes them to developing pisogenic papules. And sometimes you'll find it's not just on the calcanei, you'll see it on the wrist as well, as seen here. Pisogenic papules. Now of interest, remember it's connective tissue disease. When you look at the diagnostic criteria for hypermobile Ehlers-Danlos syndrome, look at one of the diagnostic criteria, bilateral pisogenic papules. Again, there's overlap between these two disorders. Varicose and spider veins often complicate lipedema. If you look at Dr. Herb's series, up to 100% of these patients have associated spider and varicose veins. Why is this occurring? Laxity in the surrounding dysfunctional connective tissues. In fact, when you look at the clinical manifestations of Ehlers-Danlos syndrome, you'll see predisposed to varicose and spider veins. Cutaneous hypothermia. This is a very, 5 more minutes, very interesting phenomenon. If you palpate these patients' limbs, they're usually extremely cool. Very, very cool skin. Now, why would they have that? That's a discussion we can talk about at the end of the talk. And when you stand them up, if you note there, not only are they cool, they have this erythrocyanotic discoloration as seen here. When they're standing, note that reddish purplish appearance. Even better example from a patient of ours from the study. Look at that reddish purplish discoloration. A lot of times people say, oh, it looks like stasis to me. It goes away when they're recumbent. It's not stasis. It's pooling from erythrocyanosis. As Jonathan showed on his slide, it's partially mediated by loss of the veno-arterial reflex. And also, if you do a very close inspection, not only is their skin cold, it's erythrocyanotic. What do you see here that's not uncommon? And all these are all patients with lipedema. You see this reticular lace-like modeling? That's livedo-reticularis. That's very common in your lipedema patient if you simply pay attention to them. And note, it's very illustrative on this one on the far right-hand side of the screen. That's an upper leg type, a type 2. Where do you see the livedo? You only see it in the areas of the diseased fat. Very, very, very interesting, I think. Because normally you see livedo down in the distal portions of the extremity. And finally, it's really interesting if you look at the extra-articular manifestations of your hypermobility spectrum disorders or joint hypermobility syndromes, you'll see that they eerily parallel those of the signs and symptoms in lymphedema. Again, these protean manifestations. So let's go through. On the left here, we have joint hypermobility syndrome. On the right, we have our signs and symptoms in lipedema. Number 1, joint hypermobility syndrome, chronic pain syndrome. Lipedema is a chronic pain syndrome. Chronic fatigue syndrome. If you look at your lipedema patients, up to 90% of these have significant fatigue. Up to a third of them have flu-like symptomatology. Functional gastrointestinal disorders, such as early satiety, abdominal pain, bloating, very common in both of these disorders. Chronic headaches. Up to half of your patients with lipedema have migraine headaches. Very, very common in joint hypermobility syndromes. Now, note here on the signs and symptoms of lipedema, a couple more minutes. What do you see here? Frequent urination complicating up to 2/3 of the patients with stage 3 lipedema. When I first saw it, I was going, well, why would a patient with lipedema have frequent urination? It just doesn't make a whole lot of sense. But then when you realize that patients with joint hypermobility syndromes, diseases of loose connective tissue, they have associated pelvic dysfunction from pelvic floor laxity. So I think that's what links these two disorders. Cardiovascular dysautonomic manifestations, we just referenced those with the cutaneous hypothermia, the erythrocyanosis, the livedo-reticularis, and by the way, they're also predisposed to orthostatic intolerance. And finally, a whole other discussion is the immune dysregulation that complicates both these disorders. There appears to be a link with mast cell activation syndrome. Very important point. So when you see these two patients here, do these patients have lipedema or obesity or both? Because it can be really hard to distinguish between these two disorders. So here's three ways that I typically, when I examine the patient, to try to delineate between obesity or both. Number one, do they manifest that characteristic clinical triad of orthostatic edema at the end of the day, pain and tenderness? Again, extremely important. If they don't have pain or tenderness, I'm not convinced they have lipedema. And finally, susceptibility to easy bruising. That's number one. Number two would be go back and look at an old picture before they came obese. And if they can show you a picture with that pear-shaped configuration right there, that's extremely helpful. You know, people still have to have it on their iPhone from 15 years ago, and they'll show you their phone. You go, oh, yep, looks like you have lipedema. That's a pear-shaped body. And then finally, and then really importantly, did they have diet-resistant leg swelling? That they'll tell you that even when they lost 50 pounds or when they underwent gastric bypass surgery, that even though their legs may have improved a little bit, the improvement was disproportionate. It was primarily within their torso, not their legs. So these are three ways that can help you distinguish between lipedema, obesity, or do they have both? Because up to 80% of lipedema patients are either overweight or have obesity. So in conclusion, lipedema syndrome, get used to seeing that in the literature, really hasn't made it yet with the exception of one article. It's not just about big legs, it's about arm swelling, it's about pesogenic papules from the associated dermal laxity, it's about frequent urination from pelvic floor laxity due to the dysfunctional loose connective tissue. We talked about the joint hypermobility, another reverse Neumasti sign, note the livedo reticularis, note the pes planus, and finally in the subject on the right there with the pronounced upper limb type, look at the discoloration or erythrocyanosis in the legs. I mean, you tend to focus on the thighs, but if you look at the calves, they have erythrocyanosis. It's a disorder of the loose connective tissue disease. Thanks for your attention.